I'm Sid Coleman, and this is a basic introduction to the technique of structural fat grafting. In the mid-80s, I began using fat grafting for the correction of iatrogenic liposuction deformities. I had such great success with those initial attempts that I began using fat grafting to create or restore fullness in the face. Dramatic changes in the size and form of a face can be accomplished with structural fat grafting. Restoration of fullness not only rejuvenates a face, but also can rejuvenate the hands or other parts of the body. The ability to restore or add fullness to the subcutaneous tissues of the face and body gives us a new set of tools with which to approach our patients for both enhancement and rejuvenation. And it gives us a chance to reevaluate our current rejuvenation and enhancement practices. All of the results you've just seen were accomplished with fat manipulation alone. No excisional or suspension procedures. And structural fat grafting is not limited to enhancement and rejuvenation, but also can be used both profound and subtle changes in our reconstructive patients. I will begin by describing the method I have developed for harvesting fatty tissue. Then I will describe to you the method I use for refining the harvested tissue. And finally, I will give you a brief explanation of the methods of placement which I use, with particular attention to the instrumentation or cannulas which I have developed in order to place fatty tissue. After an incision with a number 11 blade, the fluids are placed with a Lammus infiltrator. When I use general or epidural anesthesia, I infiltrate Ringer's lactate with 1 to 400,000 of epinephrine, primarily for hemostasis. I infiltrate about 1 cc for every cc I'm going to harvest. When I use local anesthesia, I use 1/2% lidocaine with 1 to 200,000 of epinephrine in the same ratio. When harvesting the fatty tissue, one should try to minimize mechanical trauma. I think the best way to do that is to gently pull back on the plunger, not more than 1 or 2 cc marks. The cannulas come in a 22 and 15 centimeter length and are blunt with a dull opening. This method harvests fat through a lower lock aperture. Fat harvested through such an aperture can usually go through a 17 or 18 gauge cannula with relative ease. I have found that 10 milliliter syringes are the best for harvesting the fat. After I fill the syringe with 10 milliliters of fat, I pass it off to my assistant, who removes the cannula and replaces it with a dual function luer lock plug for capping. The plunger is then removed and the syringe is placed into the centrifuge. A non-sterile person will then close the centrifuge and turn the dial on the centrifuge past 10 and then back to 3 to allow the centrifuge to run for 3 minutes. A circulating nurse will open the centrifuge and a scrub technician removes the centrifuged syringe, initially pouring off the oil contents into a container. The cap is then removed from the end of the syringe by twisting it off. This allows the liquid portion to drain into another container. A Codman pad is then placed into the top of the syringe, touching the fat but not pushed down into it. This allows the remaining oil to wick into the pad, thereby making a more pure specimen of fatty tissue. I suggest that the assistant changes the wicks at least twice and leaves the wick in at least 2 minutes each time. After the final wick is removed, the plunger is replaced by allowing the column of fat to slip down through the syringe and then pushing it forward. The fat can be stored in this fashion, or it can be transferred immediately into 1 cc syringes in the fashion shown. The plunger is then placed back into the syringe and it's placed into a bowl. I infiltrate fat into the hands and face using only 1 cc syringes. These are filled with fat and attached to blunt, infiltrating cannulas. Occasionally, I find it necessary to use pointed or even sharp cannulas to infiltrate adherent scars or adhesions of other types. I only infiltrate the fat during the withdrawal phase. That is, I place my finger on the plunger, and during the withdrawal of the blunt cannula, a tiny amount of tissue is placed. Now let's talk about the cannulas. I've over the years developed 9 different types of cannulas. 6 straight blunt, 2 pointed, and 1 curved. Of those, the 6 straight blunt I'll discuss first. The original cannula was blunt and completely capped on the end. I've now labeled that a type 1. The type 1 is completely capped on the end and blunt. Therefore, it is somewhat difficult to push through some tissues. To overcome this, I developed the type 2 cannula, which is not completely capped on the end and slightly open. Because it is a little sharper, I find that it is easier to push through tissues, and I use it probably more often than any other cannula for that reason. However, there are situations in which the type 2 tip is difficult to push through tissues, and in those situations I revert to a type 3, which is a more spatulated, flat end and is much easier to place through the tissues than either the type 1 or the type 2 tips on the cannulas. To better help you understand the configurations of the tips of these 3 different cannulas, here is a side view with a close-up showing that the type 1 is the most blunt. Type 3 is a flat end, and type 2 is in between. The type 1 is safer around nerves, vessels, and glands, and therefore I use it to infiltrate my local anesthesia, trying to avoid damaging the fragile vessels in an area. Because there is no cutting action with this cannula tip, I believe it provides the most stable placement. So I use it for any area that I'm worried about the stability of the placed fat. The flat end of the type 3 cannula is easier to push through tissues. Therefore, I use it any place that I'm going into a scar or fibrous tissue. I also think I have more control when using the type 3 cannula. Therefore, I use it in the lower eyelid when I'm against the very thin skin or when I'm in the mucosa, which is easy to accidentally perforate if too much pressure is applied. And the type 2 cannula I use in most other situations when I am not as concerned about damaging underlying structures and I don't need the benefit of a sharper cannula to push through fibrous tissues or to give me added control in placement against thin skin. Frequently, I use curved cannulas on the face. For instance, to place tissue into the dorsum of the nose, from the forehead, I will use a curved cannula through the nasion and glabella. When placing tissue immediately against the bone in the malar prominence, I will use a curved cannula. But probably the most common use of the curved cannula is just simply to navigate soft tissue in order to place tissue immediately against the skin or immediately against the bone when it is appropriate to do so. For freeing up adherent scars, I use a cannula fitted with two pointed tips which are not cutting. I also have developed a sharper cutting version of that tip for more adherent subcutaneous scars. I use it for freeing up adhesions and placing tissue to elevate depressed scars, such as this lateral eyelid blepharoplasty scar. The most common use in my practice, however, is with acne scarring, where adherent ice pick type scars and even flat scars can be freed up and fat placed immediately into the resulting space to provide results such as these. Using structural fat, we can make dramatic and subtle changes in the shape and volume of our patients' faces, both for reconstructive and cosmetic reasons. This patient with an 8-year follow-up demonstrates my consistent experience that fat grafted in the manner described has every indication of permanence. For listings of upcoming courses or other information on structural fat grafting, please refer to the lipostructure.com website.